Very good afternoon to all of you. I would like to thank the organizers for giving me this opportunity to come back again to this institution where I was trained. So we had surgery, we had radiation. So what is the role of chemotherapy? Is there any role at all in early cervical cancer? And for the fellows, as you know, there are 4 scenarios where we can use chemotherapy in any solid tumor, either as the primary treatment, like in, say, lymphomas, as an adjuvant treatment after surgery to improve the long-term outcome, as a neoadjuvant before surgery to shrink the tumor, facilitate surgery, and then improve the long-term results as well, and as concurrent also during the radiotherapy to improve the results. And obviously there is another one, palliative, which is not our topic of discussion. But all guidelines recommend chemotherapy in early cervical cancer only in the concurrent setting if there are high-risk features in the final specimen of surgery. There is no mention of adjuvant or neoadjuvant chemo in any guidelines. But there are potential uses, like for example, after radical surgery, if we can spare radiotherapy and give only chemotherapy, that can reduce some of the long-term effects of side effects of radiotherapy. We may use it after chemoradiation to improve the results, but in early cervical cancer, the results are usually good with surgery plus minus concurrent chemoradiation, so this is probably not required. We can use it as neoadjuvant chemo before surgery to number one, to spare radiotherapy, again like adjuvant chemotherapy, and also to shrink the tumor and facilitate the surgery. And as an extension to that, in fertility preserving approach, where you give a neoadjuvant chemotherapy, as Dr. Shunes said, to shrink the tumor and do a fertility preserving surgery. So first of all, adjuvant chemotherapy. This is important because radical surgery in most of the case should be good enough for local control and to improve the distant failure rates. So we can just use chemotherapy sparing radiotherapy, provided there is no gross residual tumor. Chemotherapy can reduce the side effects of radiation. This has already been discussed. So we need to understand the risk stratification after surgery based on the final histopath report. That will dictate the treatment. These are some of the studies done in early cervical cancer, which have shown that, number one, in this study by Rotman et al., they showed that in intermediate risk group, after surgery, radiation therapy improves the progression-free survival. So it's a standard practice to add in these patients radiation therapy. Now there is another study by Cartin et al. It's a very small study, but they showed that as compared to chemoradiation, chemotherapy also achieves probably the same thing in intermediate or in high-risk tumors. There is another seminal paper by Peters et al., which included only the high-risk patients and compared chemoradiation along as compared to radiotherapy, and the 4-year DFS and overall survival was significantly better in favor of chemoradiation. So based on, and there was one single study published in 2012 which compared 2 regimens, one of sequential chemoradiation, another concurrent chemoradiation. There was no difference in between the two. So based on all this data and some other studies, we have the Cochrane meta-analysis recently updated in 2016, which suggested that adjuvant cisplatin-based chemotherapy after radical surgery, radiotherapy, or both, and it was compared where chemotherapy was not used, adjuvant chemo was not used, these 2 groups were compared in stage 1A2 to 2A with at least one of those risk factors for recurrence, either intermediate or high. There were total 400 patients, and as compared to adjuvant radiotherapy, if you add chemoradiation, it significantly reduced the risk of death and also disease progression, but there was more acute grade 4 toxicity in the chemoradiation group. And in the one small study which I mentioned, which compared chemotherapy followed by radiation, there was no difference in disease recurrence. Apart from the randomized studies, there was also a retrospective analysis which was done from China. They did in their almost 2,200 eligible cases from their cervical cancer database. And they found in those, they included 1B to 3B, so more advanced cases were also included. So they included patients who were treated with radical hysterectomy and bilateral lymphadenectomy, but who received either chemotherapy or radiotherapy, but not both as adjuvant. Now, this adjuvant for them, it could have been neoadjuvant as well, few patients, but most patients received in the adjuvant setting. Now, those in the chemotherapy group had more risk factors as expected, because these are retrospective analysis. They had larger tumor size, more of adenocarcinoma or adenosquamous histologies, later disease stages, and there was no significant difference between the treatment groups for 5-year overall or disease-free survival rates. But there was marginally improved outcomes improved in the chemotherapy group in the entire population. Overall survival 86.5 versus 82.8. But in a subgroup analysis, those in stage B, 1B, they had very significant improvement. The p-value was less than 0.001 in both overall survival and DFS rates. So one thing is clear, that there is some data for suggesting adjuvant chemotherapy without going for radiation, though it may not be the standard. And an interesting paper from the Japanese gynec oncology group, they looked at their member institutions and found that if there is an intermediate risk patient after surgery, at 33% of the institutions, they were treated by adjuvant chemotherapy alone. And this was the most common treatment, as compared to chemoradiation in 26% and only radiation in 28% institutions. But if it was a high-risk patient, then chemoradiation was the most common, 57.9% as expected. So people are doing adjuvant chemotherapy sometimes, especially the intermediate risk cases. Now, coming to neoadjuvant chemotherapy, there are a few studies of neoadjuvant chemotherapy before radiation in patients with early cervical cancer, but unfortunately the response rates and survival rates were not improved in any of those. There were various mixed bag of regimens were used, and the lack of survival advantage was attributed to the lower CR rates of chemotherapy. None of them are taxane with platinum chemotherapy, which is the standard nowadays. Lower dose of cisplatin used, fewer cycles of chemotherapy, relatively inactive regimens, and frequent interruptions in the radiation treatment. There are few studies of neoadjuvant chemotherapy plus minus surgery. So here the experimental arm was neoadjuvant chemotherapy followed by surgery, and in the other arm mostly there was surgery. Some patients who are inoperable even after neoadjuvant, they were given RT. Now, as you can see, some studies have shown some benefit. For example, in this study a study by Benedetti, Panisi et al., they showed that the 5-year overall survival was 58.9% in favor of neoadjuvant chemotherapy, as compared to 44% in the only surgery or radiotherapy arm. So the next question comes, how to synthesize all of those data. A meta-analysis, this is by the Cochrane group in 2012, which compared randomized trials, included randomized trials comparing NSCT with surgery with early or locally advanced disease. There were more than 1,000 women, and they found that both the overall survival and the progression-free survival were significantly improved with neoadjuvant chemotherapy. And the estimate for local recurrence was also in favor of neoadjuvant chemotherapy. But the authors admitted that there was a lot of heterogeneity and not all of the studies were of good quality. And in exploratory analysis of pathological response showed that the adverse histological findings were reduced with the use of neoadjuvant chemotherapy, like lymph node status or parametrial infiltration were less if neoadjuvant chemotherapy was given as compared to upfront surgery. So thereby you could possibly avoid radiation in the post-op setting. Last part, neoadjuvant chemotherapy for fertility preservation. As we heard from the earlier excellent talk, that less than 2 centimeter disease, fertility preserving can be done probably straight away. But for 2 to 4 centimeter FIGO stage 1B1 and 2A disease, We can use neoadjuvant chemotherapy, which can reduce the nodal metastasis, reduce the parametrial infiltration, the overall tumor size, theoretically making otherwise unresectable in the terms of fertility preservation, amenable to fertility preserving surgery. These are some of the studies very nicely summarized in one article by Willows et al. Published last year only. They included all the studies where 5 or more patients of fertility preserving surgery cases were reported after neoadjuvant chemotherapy. Various regimens were used, taxane, platinum, or taxane with etoposide platinum. Dose-dense regimens were also there. The lymph node assessment in some patients was done before neoadjuvant and in some patients after neoadjuvant chemotherapy. But what they found was that in more than 80 patients thus included, the crude recurrence rate was only 6.3%, and one patient only died from the recurrent disease. And the use of NSCT resulted in at least 36 pregnancies with 72% live birth rate. So the key messages which I would like to give is that after radical surgery, the adjuvant radiation or concurrent chemoradiation, if there is intermediate or high risk features respectively, is the standard. So this only standard where we can recommend chemotherapy is if there is a high risk histology after primary surgery. But adjuvant chemotherapy may be an acceptable alternative in the intermediate risk group to reduce the adverse effects and preserve ovarian function. And neoadjuvant chemotherapy prior to surgery, it may improve the PFS and OS as is evident from the meta-analysis, though not all the studies are of good quality. But it can eliminate the need for radiation and reduce the toxicity. But even then, it is still not in the guidelines. So we may use it as a part of institutional protocol or after one-to-one discussion. And obviously, neoadjuvant chemotherapy is important role is there in fertility preservation in 2 to 4 centimeter tumors in women those who want to preserve fertility. Thank you.